Hello, everyone. Welcome, and thank you for joining us today to discuss how collaboration amongst different healthcare providers can help to improve colorectal cancer, or CRC, screening rates and close the CRC screening gap one patient at a time. My name is Dr. Dan Newman, and it's my pleasure to be moderating today's discussion. I'm a practicing gastroenterologist and the president of Capital Digestive Care, located in the Mid-Atlantic region. I've been practicing for 20 years in the field of gastroenterology. Today, we'll be discussing the burden of colorectal cancer, choice and the shared decision-making, the science behind Cologuard, and available resources. Colorectal cancer is very important to what I do as a gastroenterologist. Colorectal cancer is one of the leading causes of cancer in this country. There's a great deal of things that we can do to prevent and treat colon cancer. Before starting the discussion today, I'd like to introduce the panelists who are here with me, starting with Dr. Raymond Wadlow.
Hi, my name is Dr. Raymond Wadlow from Inova Shar Cancer Institute, located in Fairfax, Virginia. I am a medical oncologist with 16 years of experience that sees patients if they get diagnosed with CRC after they complete their screening.
Hi, my name is Dr. Timothy Quinn from Quinn Healthcare, located in Ridgeland, Mississippi. I am a primary care provider with 19 years of experience that sees patients regularly about CRC screening.
My name is Dr. Lillian Shapiro, founder of Ideal Gynecology, serving the greater Atlanta area in Georgia. I am a gynecologist with over 20 years of experience and see patients regularly to discuss colorectal cancer screening as part of their annual Well Woman exam.
It's so great to have such a robust panel of CRC experts here today, and I'm really looking forward to this in-depth discussion. Please feel free to submit your questions in the Q&A box throughout the presentation and stick around for the Q&A session with our panelists once the presentation has concluded. Dr. Wadlow, can you help set the stage and highlight the importance of today's discussion by telling us a bit more about the current state of CRC and CRC screening in the U.S.?
CRC is the second leading cause of cancer deaths in the U.S. However, some could be prevented. The American Cancer Society estimated that in 2022, there will be approximately 150,000 new cases of CRC and approximately 53,000 deaths from CRC. A simulated study found that with a screening rate of 100%, approximately 35,500 additional deaths from CRC could be prevented over a lifetime in a single-year cohort of 50-year-old adults. A diagnosis of colorectal cancer can be devastating to patients and their loved ones. Based on my experience, treatment regimens will vary by patient. Many patients will require abdominal surgery, chemotherapy, and could even develop metastatic disease to which they will ultimately succumb.
Agreed. And this brings us back to the goal of today's discussion: to increase awareness and enhance efforts to increase CRC screening. We want to emphasize that CRC remains the most preventable, yet least prevented cancer. Now I want to talk a little bit about why early detection and prevention is so important. Early detection of CRC is associated with improved survival, but the majority of patients are diagnosed at later stages.
In patients diagnosed with earlier stages of CRC, the 5-year survival rate is 91%. As we get into the later stages, the 5-year survival rate drops to 15%. Furthermore, more than 50% of patients with CRC are diagnosed with late-stage disease. While patients with metastatic CRC are living longer and better lives, with a median survival now approaching 3 years, fewer than 1 in 5 will live for 5 years. Although it's a tremendous honor and privilege to care for these patients and their families, it's heartbreaking to acknowledge the disrupted plans and shortened lives. We have seen varying trends in CRC prevalence among different age ranges. Dr. Shapiro, can you tell us more about how CRC is affecting the younger population in particular?
Sadly, the incidence of colorectal cancer is increasing in patients younger than 50 years old. According to the American Cancer Society guidelines, as of 2018, there was around a 51% increase in CRC incidence among these patients within a 20-year period. Additionally, A second retrospective study found that patients younger than 50 years old were more likely to be diagnosed with advanced stages of colorectal cancer compared with those 50 years or older. This is an alarming percentage as we tie this back to what Dr. Wadlow has just discussed. The 5-year survival drops to 15% in patients diagnosed with later stages of colorectal cancer. Dr. Wadlow, do you see a similar trend with an increased number of younger patients getting diagnosed at advanced stages of colorectal cancer?
This is something that I am seeing in my practice and would hate to see the numbers rise further. The diagnosis of CRC in a younger patient presents unique challenges that have significant negative impact on quality and quantity of life, including increased infertility, long-lasting nerve damage, gastrointestinal symptoms, and psychological distress. Many of these problems create substantial difficulties for young adults with career aspirations, financial stressors, and new families.
We just discussed how the overall incidence of CRC is increasing in patients younger than 50 years. What are the national organizations doing to address this? The ACS, USPSTF, USMSTF, ACG, and NCCN now recommend routine CRC screening for all average risk patients between the ages of 45 and 75 years.
In May 2018, the American Cancer Society was the first to revise its colorectal cancer screening guidelines to include patients starting at 45 years of age. I'm fortunate to see my patients almost every year, and so when they turn 45, I talk to them about colorectal cancer screening. Dr. Newman, can you tell us what you think about these updated guidelines?
What we've seen over the years is that adenomas, or precancerous lesions, have been identified in those patients under the age of 50. This has led to the new guidelines of lowering the screening rate from age 50 to 45, with the intention of early detection and reducing the overall prevalence of colorectal cancer. Dr. Quinn, to put this into perspective, how do these recommendations affect the number of people who are eligible for colorectal cancer screening?
Guideline recommendations to lower the screening age to 45 years old increase the patient population eligible for CRC screening. Around 19 million more adults are newly eligible for screening, bringing the total number of eligible adults between 45 to 74 years of age to approximately 44 million. It is important that we, as providers, are vigilant with screening. In fact, the National Colorectal Cancer Roundtable, or NCCRT, mentions that we will be a strong factor in changing the mindset of 45 to 49-year-old adults, as our recommendations are strongly respected. We all need to work together to help close the CRC screening gap and get 44 million eligible average-risk patients successfully screened for CRC.
I agree that we need to work together to solve this problem. The CRC care continuum requires a multidisciplinary team approach in which we are a part. The patient's journey starts with the initial interaction between an HCP, either at an annual visit or other encounter, and either ends with screening or proceeds to the gastroenterologist or colorectal surgeon. Unfortunately, if the patient is diagnosed with CRC, their journey can proceed to a medical oncologist like myself. We all play a big role in this journey, and it all starts with routine CRC screening for every eligible patient.
Dr. Wadlow, you just mentioned that we need to all work together to close the CRC screening gap. But why is there such a large gap in screening? Well, some of it is due to patient barriers. Some patients lack knowledge about CRC screening. Patients are prioritizing other life demands over screening and have logistical hurdles like getting an appointment and taking time off work. Patients are concerned with cost as it relates to CRC screening. COVID-19 decreased CRC screenings and in-office visits. Patients are fearful of having an unfavorable screening result. Social determinants that affect health equity include race, education, low income, and access to technology can all affect patients from seeing their doctors and getting screened. As a primary care physician, I experience patients on a daily basis that articulate many of these barriers, such as taking time off work due to the fact that a lot of these patients articulate that they won't receive payment when they're not at work. But with the other options to include the stool-based screening, such as Cologuard, now patients have an option where they don't have to take time off work and they can still get these very important screenings that can change their lives for the better. In addition to patient barriers, healthcare provider barriers to CRC screening exist. Barriers that we experience to CRC screening can include those on the patient, provider, and clinic levels. One obstacle we run into is not having enough time in the clinic to discuss screening. Our practice is in Mississippi, one of the most hard-hit communities as far as patient-to-physician ratio, resulting in practices overwhelmed with great numbers of patients with limited time to provide the education about the importance of colorectal cancer screenings. But what we have to do as physicians, as healthcare providers, is we have to really put an emphasis on providing those educational opportunities to our patients to increase the prevalence of colorectal cancer screenings. Lack of logistic services can impede the completion of CRC screening. Often there is a lack of staff to complete patient follow-up. As healthcare providers, we are an integral part of multi-pronged approach to help increase adherence to CRC screening.
Dr. Quinn, I agree. Well said. We need to break down these barriers, and we need to work together to help get every single eligible patient screened for colorectal cancer. Now that we have an understanding of the burden of CRC and the important role healthcare providers play in increasing CRC screening rates, Dr. Shapiro, can you talk about the importance of adopting informed choice and shared decision-making to help make that happen?
Generally speaking, offering choices to a patient is something we can all attest to for various topics of conversation, especially if choices are available in the context of screening and preventive health. National colorectal cancer screening guidelines have recommended offering patients a choice for more than 5 years. This is done in order to maximize screening, improve screening rates, and help reduce colorectal cancer deaths. In 2016, the USPSTF recommended offering patients a choice in colorectal cancer screening strategies to help increase uptake in screening. The latest American Cancer Society guideline recommends offering patients a choice of CRC screening tests rather than recommending a single test. They felt that greater value should be placed on increasing CRC screening utilization through offering a choice. As an update from the 2016 guidelines, the 2021 USPSTF guideline recommends discussion with patients to better identify tests that will be more likely to be completed by a patient. In fact, a study was published by Inadomi and colleagues in 2012 to show the influence of choice in colorectal cancer screening rates. In a randomized study of patients at average risk for colorectal cancer, healthcare providers provided patients with colorectal cancer screening recommendations for FOBT, colonoscopy, or their choice of the two options. At 1 year, the FOBT arm had 67% adherence, but the colonoscopy arm had a lower adherence of only 38%. However, in the choice arm, 69% of patients were adherent. There was a 31% absolute increase in patient adherence in choice arm versus colonoscopy alone. When patients were given a choice, adherence rates nearly doubled over colonoscopy alone. In my office, when I'm talking to women about colorectal cancer screening, I always mention that they can choose to either have the Cologuard test or colonoscopy. From my perspective as a provider, both just involve putting an order in the computer, but to the patient, it makes all the difference to have been offered a choice. Dr. Quinn, how do you offer choice to your patients?
In regards to offering choice to patients with various options after education, patients have overwhelmingly articulated favor in this scenario where they can make a choice based on their particular situation. And as a medical provider of 19 years, I can tell you that I've seen a much higher prevalence of patients following through getting those colorectal cancer screenings when they were offered choices of various options?
I have to say that providing patients with choices is really important. The power of offering a choice versus only one option can really change how a patient reacts and ultimately adheres.
I want to reemphasize what you said, Dr. Newman. Talking with the patient and not talking to a patient changes the tone of the conversation, which brings me to the topic of shared decision-making. This is a process by which the providers and the patients reach an optimal decision together. In shared decision-making, we as healthcare providers offer options and describe the risk and benefits, and the patient expresses his or her preferences and values. National organizations highlight the importance of shared decision-making. The USPSTF values and affirms that patients have the right to be informed and participate in healthcare decisions, and that shared decision-making is a means to this goal. The ACS states that offering choice allows recognition of the role of patient values and preferences and is a strategy to improve adherence. In fact, a study was published by Verma and colleagues in 2022 to show the influence of shared decision-making on acceptance of CRC screening. Providers implemented a balanced approach to CRC screening options, educated patients on screening, and encouraged average-risk patients to make their own informed choice. Before implementation, 35% of patients declined CRC screening. After implementation, the percentage decreased to 6%. This study shows that information and guidance from clinicians help patients select the best CRC screening tests they would choose for themselves. Dr. Shapiro, can you share with us a little bit about how you implement shared decision-making within your practice and interactions with patients?
Patients are very savvy these days, and I think it's important that we know the choices that they have, because they most likely will also know the choices. My patients are very happy to hear that I am supporting them in having a choice about what type of colorectal cancer screening works for them and in their lives.
That is something many of us can relate to. Dr. Wadlow, can you share with us a little bit about how you implement shared decision-making within your practice and interactions with patients?
Shared decision-making requires a relationship built on trust, and that takes time and effort for which there are no shortcuts. I begin by actively listening to the patient's concerns, followed by educating the patient about the range of options available, and finishing with a discussion about each patient's understanding and preferences. As we all appreciate the importance and value of shared decision-making in treatment decisions, it is equally as important to have these types of conversations with your patients for CRC screening.
Great insights here. This goes hand in hand with offering choice so that patients can ultimately make an informed decision. One option for CRC screening is Cologuard. It can be used when presenting choice to patients to help inform the shared decision-making process. Before going into the clinical data, I want to take a few minutes to overview the science and technology behind Cologuard. Let's take a look at how something as simple as a stool sample can provide important results. What is cellular exfoliation, and what does a single stool sample really tell us? Cells are constantly being shed into the stool as it progresses through the colon and the rectum. Hemoglobin and DNA are included. Therefore, cellular exfoliation can present a snapshot of potential precancerous growths and colorectal cancers. Detection of these advanced precancerous lesions is essential for colorectal cancer prevention. This is important to keep this in mind as we continue to talk about Cologuard's multi-stool DNA technology compared to FIT. Now that we reviewed what a single stool sample tells us, let's take a look at how that applies to Cologuard and FIT. If you compare Cologuard to FIT, Cologuard detects 11 biomarkers, which include altered DNA and hemoglobin, whereas FIT only detects hemoglobin. Cologuard also detects biomarkers continuously shed in the stool, whereas FIT detects only hemoglobin in the stool from polyps or lesions that bleed intermittently. Cologuard consistently detects both left and right-sided cancers, and the detection of proximal cancers in FIT is inferior to that in Cologuard based on a clinical study. Ultimately, Cologuard is designed to produce a qualitative result. It is important for all clinicians to keep these differences in mind when making a decision on a stool-based test for colorectal cancer screening. Dr. Quinn, can you provide us some additional information on what the qualitative result means for the clinician and for the patient?
Absolutely. Cologuard's qualitative result is important for us as clinicians to understand so that we can give the proper guidance to our patients. The Cologuard result is determined by a composite score based on the patient's biomarker assay results. Cologuard reports that are sent to the ordering healthcare providers show a single result, either negative or positive. A negative result means Cologuard did not detect abnormal DNA and/or hemoglobin biomarkers in the stool that are associated with CRC or advanced adenomas. In this case, we would tell our patient that even with a negative result, they should continue with a screening program that is appropriate for them. ACS recommends screening for CRC again 3 years after a negative Cologuard result. A positive result does not necessarily mean a patient has cancer. It means Cologuard detected abnormal DNA and/or hemoglobin biomarkers in the stool that are associated with CRC or advanced adenomas. In this case, we would tell our patients that a positive result means they should schedule a follow-up colonoscopy. False positives and false negatives occur with Cologuard, and appropriate follow-up is important. In our practice, after receiving the results of the patient's test that have participated in the Cologuard screening, we contact the patients, and overwhelmingly, the patients express a great deal of gratitude because now they have the information they need to make the proper decision that can change their life for the better. Dr. Shapiro, what has your experience with Cologuard test results been like?
Cologuard test results are received to the office and to the patient. It's very simple. It comes as a positive or negative, and reach out to the patient to make sure that the patient understands that if it's negative, they need another test in 3 years. And if they have symptoms, they still need to see a gastroenterologist. We especially reach out to them for any positive results to make sure that they have rapid follow-up with a colonoscopy.
Appropriate follow-up for patients who have a positive Cologuard is of the utmost importance. It's very important that patients are referred for colonoscopy to a gastroenterologist to follow up on any positive Cologuard result. Now that we've discussed the science and technology of Cologuard and how to interpret test results, let's dive into a few studies to help us learn more about this screening test.
First, let's review the design of the pivotal study, which was published in the New England Journal of Medicine. This was a prospective, head-to-head, 90-site study of approximately 10,000 patients aged 50 to 84 years at average risk for CRC who were scheduled to undergo screening colonoscopy. Patients were excluded from the study if they had a colonoscopy in the past 9 years, a double contrast barium enema, virtual colonoscopy, or sigmoidoscopy within the past 5 years, a personal history of colorectal neoplasia, digestive cancer or IBD, a personal or family history of CRC, or a positive fecal blood test result within the past 6 months. All participants included in the primary analysis had Cologuard, FIT, and colonoscopy. The primary outcome was the sensitivity and specificity of Cologuard to detect CRC with colonoscopy as the reference method. The secondary outcomes were Cologuard detection of advanced precancerous lesions with colonoscopy as the reference method, CRC and advanced precancerous lesion sensitivity of Cologuard compared to FIT. Dr. Quinn, can you help us understand more about the key statistical measures used in this study?
Of course. Now that we know the study outcomes, let's take a deeper look at the 3 key statistical measures. Sensitivity is the true positive rate and is defined as the proportion of persons with disease who have a positive test. In other words, positive test results among persons with disease. Sensitivity was determined by calculating the proportion of patients who had a positive Cologuard or FIT test compared to actual positive tests determined by finding on a colonoscopy. Specificity is the true negative rate and is defined as the proportion of persons without disease who have a negative test. In other words, negative test results among persons without disease. Specificity was determined by calculating the proportion of patients who had a negative Cologuard or FIT test compared to actual negative results determined by findings on a colonoscopy. Negative predictive value is the proportion of persons with a negative test truly absent of disease. Now that we know how the study outcomes were analyzed, let's discuss the results of the study. In the pivotal study, Cologuard showed superior sensitivity compared to FIT in detecting CRC and advanced precancerous lesions. For the sensitivity, Cologuard identified 92% of patients with any stage of CRC compared with 74% of patients with FIT. Cologuard identified 94% of patients with early stage CRC compared with 70% of patients with FIT. Now, let's take a look at the advanced adenoma sensitivity results. Cologuard identified 42% of patients with advanced precancer and 42% of patients with sessile serrated polyps greater than or equal to 1 centimeter compared with FIT, which identified 24% and 5% of patients respectively. FIT failed to detect 3 times more total findings in all stages of CRC and missed 8 times more sessile serrated polyps compared with Cologuard. Generally speaking, Dr. Newman, can you discuss the current limitations in adenoma detection?
Absolutely. What I want to highlight here is that detecting advanced adenomas is important, but there's no perfect way to detect them. Detection widely varies between screening methods. While colonoscopy remains the gold standard for colorectal cancer screening, there is no perfect test, and all tests have some limitation.
Very interesting, Dr. Newman. Now, to continue with the study results, the overall specificity of Cologuard excluded CRC and advanced adenomas and included all non-advanced adenomas, non-neoplastic findings, and negative results on colonoscopy. Of 9,167 patients, 13% tested falsely positive with Cologuard and 5% tested falsely positive with FIT. Thus, the specificity of Cologuard was about 87% in this population versus 95% in patients tested with FIT. Of 4,457 patients with negative results on colonoscopy, 10% tested falsely positive with Cologuard and about 4% tested falsely positive with FIT. Thus, the specificity of Cologuard was about 90% in this population versus 96% in patients tested with FIT. Dr. Watlow, now that we know who tested negative with Cologuard, can you explain a little about what the negative predictive value results were?
Cologuard helps to determine if patients need a colonoscopy and provides reassurance through negative results. Negative predictive value is defined as the probability that disease is absent in those with a negative result. When extrapolated to 10,000 patients, if a patient received a negative test result, there was a 99.94% chance that there would be no CRC. In clinical practice, these patients would not need to undergo a follow-up with colonoscopy. Dr. Shapiro, you discussed the younger population earlier. What are the Cologuard results for those aged 45 to 49 years?
After the pivotal trial, a prospective study of 816 patients aged 45 to 49 years old at average risk of colorectal cancer was conducted. In this study, Cologuard demonstrated 95.2% specificity in 767 patients with non-advanced adenomas, non-neoplastic findings, and negative results on colonoscopy. In fact, MT-sDNA testing is recommended in major colorectal cancer screening guidelines, including the American Cancer Society, the USPSTF, USMSTF, ACG, and NCCN for average risk patients aged 45 years and older.
This study demonstrates that Cologuard has high specificity in patients aged 45 to 49 years old. This helps to reinforce the use of Cologuard in this younger patient population. We talked a lot about choice earlier. How does the inclusion of Cologuard as a CRC screening choice influence patient adherence?
Actually, there was retrospective EHR-based study in which Cologuard use was evaluated in patients at average risk who were on Medicare and non-adherent with recommended screening guidelines. Providers ordered Cologuard tests for 393 patients who were previously non-adherent. Patients who were non-adherent included those who had gone greater than 10 years since their last colonoscopy and or greater than 1 year since their last fecal occult blood test, or FOBT. A total of about 88% of patients were adherent and completed the test. 51 patients who were screened tested positive and were advised to undergo a follow-up colonoscopy. Of these patients, about 96% were adherent and received a follow-up colonoscopy. Results demonstrated high adherence with Cologuard and subsequent follow-up colonoscopy in patients who were previously non-adherent. Dr. Quinn, what has your experience been with Cologuard and patient adherence?
In our practice, overwhelmingly, we were impacted by the COVID-19 pandemic, resulting in a lot of patients not being able to come into the clinic. This caused us to evaluate Cologuard a little more intensively because it was an option where patients could do the testing at home. And due to this increased information to patients about Cologuard, our screening rates went up drastically. So many more patients were being screened for colorectal cancer. So many patients were being diagnosed with test results, resulting in the proper referrals and patients being empowered with the information so they could make the decisions that were life-changing.
Now that we've discussed the clinical data for Cologuard, it's important for us to understand how to implement it successfully into our clinical practices. In our final segment, we will discuss patient access and important Cologuard resources for providers.
Nationwide, about 94% of all Cologuard patients have no out-of-pocket cost for screening. Currently, millions of patients have access to a follow-up colonoscopy with no out-of-pocket cost, but not all do. The fact that many patients do not have the responsibility of out-of-pocket follow-up costs for colonoscopies if they have a positive stool-based test result has a big impact on patients' adherence to following our guidance as far as following up for that very important colonoscopy. I want to take this opportunity to shed light on great news around follow-up colonoscopy cost share information. In January of this year, the Public Health Service, PHS Act, as part of the Affordable Care Act, Part 51, stated that plans and issuers for policy years beginning on or after May 31st, 2022 must provide coverage for a follow-up colonoscopy after a positive non-invasive stool-based screening test without cost sharing. More information on follow-up colonoscopy cost share information can be found on the Cologuard patient website, www.cologuard.com.
Dr. Quinn, just to reiterate, insurers will now have to cover a follow-up colonoscopy after a positive non-invasive stool-based test. This recent legislation is so important to closing the loop on colorectal cancer screening for patients who have a positive screening stool-based test.
Cologuard is a contactless test option that only requires 3 simple steps for completion. After the provider orders Cologuard for the patient, the Cologuard collection kit is shipped directly to the patient's door. The patient then provides a stool sample from the privacy of their home. Patients do not need to be sedated, don't have to take time off from work, change their diet or take any special prep, stop or change any medications, or visit a healthcare facility to complete Cologuard. The patient then ships the Cologuard kit to Exact Sciences laboratories using the prepaid UPS label, and UPS can pick up the package from the patient's home. Exact Sciences laboratories test the sample and typically provides a result to the ordering provider within 2 weeks. Note that the patient should not provide a sample if they have diarrhea, active bleeding from hemorrhoids, menstruation, or other conditions that can interfere with the test, such as cuts on their hands. So many of my patients that have participated as far as using Cologuard for their at-home screenings have done nothing but provided just feedback that has been phenomenally great. I mean, the fact that they did not have to take time off work, they could do it in the privacy of their own homes, as far as getting the results within 2 weeks, it's just been an overall great experience for all of my patients.
Cologuard has a built-in patient navigation program that helps to support the patient and encourage them to complete the screening test recommended and prescribed by their provider. Patient support is available 24/7 with more than 240 languages available. There are multiple proactive touchpoints from the customer care team to the patient, including a welcome letter and call, reminder calls, reminder emails, text messages, and a reminder letter. If the patient support team is unable to reach the patient after 60 days, the provider is notified that the patient could not be reached and has not completed their Cologuard test. I'm sure it is reassuring for all of us to know that the patients for whom we prescribe Cologuard will have a patient navigation system to support them every step of the way during their colorectal cancer screening journey.
That's great to hear. Many of my patients shared their experience as far as the navigation program associated with Cologuard, and overwhelmingly, I had nothing but absolutely wonderful reports.
With that being said, we're almost out of time. I'd like to recap this exceptional discussion. Colorectal cancer remains the most preventable, yet least prevented cancer. National organizations now recommend routine colorectal cancer screening at 45 years of age for patients at average risk for colorectal cancer. We, as healthcare providers, play an important role in the prevention of colorectal cancer and its screening. National guidelines recommend offering patients options and highlight the importance of shared decision-making. Listening to patients' values and preferences in the shared decision-making process may improve screening acceptance and adherence. We discussed the technology behind Cologuard and how it tests for 11 distinct biomarkers that produce a negative or positive result. In the pivotal trial, Cologuard showed superior sensitivity to FIT and, in a separate study, demonstrated high specificity in average-risk patients aged 45 to 49 years. Nationwide, most Cologuard patients have no out-of-pocket costs for screening. We have highlighted the new legislation stating that beginning on or after May 31st, 2022, insurers must provide coverage for follow-up colonoscopy after a positive, non-invasive stool-based screening test. Lastly, Cologuard is a contactless testing option that has built-in patient navigation programs for eligible patients aged 45 years and older at average risk for colorectal cancer. Choose Cologuard for all eligible patients aged 45 years and older at average risk for colorectal cancer. Thank you so much for joining this broadcast. I encourage you to stay for our Q&A session coming up next. Cologuard is intended for the qualitative detection of colorectal cancer neoplasia-associated DNA markers and for the presence of occult hemoglobin in human stool. A positive result may indicate the presence of colorectal cancer or advanced adenomas and should be followed by a colonoscopy. Cologuard is indicated to screen adults of either sex, 45 years or older, who are at typical average risk for colorectal cancer. Cologuard is not a replacement for diagnostic colonoscopy or for surveillance and colonoscopy in high-risk individuals. Cologuard is not for high-risk individuals, including patients with a personal history of colorectal cancer or adenomas, those who have had a positive result from another colorectal cancer screening method within the last 6 months, have been diagnosed with a condition associated with high risk for colorectal cancer, such as inflammatory bowel disease, chronic ulcerative colitis, Crohn's disease, or those who have a family history of colorectal cancer or certain hereditary syndromes. Positive Cologuard results should be referred for a colonoscopy. A negative Cologuard test result does not guarantee the absence of cancer or advanced adenoma. Following a negative result, patients should continue participating in a screening program at an interval and with a method appropriate for the individual patient. False positives and false negatives do occur. In a clinical study, 13% of patients without cancer received a positive result, a false positive, and 8% of patients with a cancer received a negative result, a false negative. The clinical validation study was conducted in patients 50 years of age and older. Cologuard performance in patients aged 45 to 49 years was estimated by a subgroup analysis of near-age groups. Cologuard performance, when used for repeat testing, has not been evaluated or established. Cologuard is available by prescription only.